Epididymo Orchitis, etiology, diagnosis, and evidence-based treatment strategies. Epididymo Orchitis accounts for approximately 1.5 cases per 1,000 men annually in the United States, representing the most common cause of acute scrotal pain in sexually active males. The condition arises from ascending uropathogenic bacteria in younger men or retrograde spread from the urinary tract in older or diabetic patients, leading to inflammation of the epididymis and testis. Diagnosis hinges on a combination of focused history, scrotal ultrasonography demonstrating hyperemia, 2 times normal flow, and leukocytosis, 10 times 10L superscript 1, and targeted microbiologic testing. First-line therapy combines a third-generation cephalosporin, ceftriaxone 250 mg IM, with a doxycycline regimen, 100 mg PO bid times 10 to 14 days, while alternative regimens address quinolone resistance or atypical pathogens. Key points. Note, incidence of epididymo orchitis in men aged 15 to 35 years is 1.5 per 1,000 person years, 95% CI 1.3 to 1.7, CDC, 2022. In men greater than 65 years, 78% of cases are associated with urinary tract pathogens, E. coli, proteus, versus 22% in younger cohorts, IDSA, 2019. Scrotal ultrasound sensitivity for epididymal hyperemia is 94%, specificity 84%, when flow exceeds 2 times baseline Doppler velocity. First-line antimicrobial regimen, ceftriaxone 250 mg IM times 1 dose plus doxycycline 100 mg PO bid for 10 to 14 days, IDSA 2019. Alternative regimen for quinolone-resistant organisms, levofloxacin 500 mg PO daily times 10 days plus azithromycin 1G PO single dose, CDC 2021. Treatment failure rate with standard therapy is 8%, NNT equals 13, in patients with underlying diabetes mellitus, JAMA SURG 2020. Scrotal pain greater than 48H without improvement on antibiotics warrants surgical exploration. Risk of testicular loss is 12% if delayed beyond 72H. Adjunctive NSAID, ibuprofen 600 mg POQ6H, reduces pain scores by 2.1 points on a 10-point VAS, P less than 0.01. In pregnancy, cefazolin 2G4Q8H for 7 days is safe, category B, and replaces ceftriaxone to avoid biliary sludging. Renal dosing. Ceftriaxone requires no adjustment down to eGFR 30 ml/min/1.73 square meter, but levofloxacin dose reduces to 250 mg daily if eGFR 30 to 49 ml/min/1.73 square meter. Overview and epidemiology. Epididymo orchitis, ICD-10N44.1, is defined as inflammation of the epididymis with concurrent testicular involvement, typically presenting as acute scrotal pain, swelling, and erythema. Global incidence estimates range from 0.7 to 2.3 cases per 1,000 male population annually, with the highest rates in North America, 1.8/1,000, and Europe, 1.4/1,000, WHO, 2021. In the United States, surveillance data from 2017 to 2021 show 12,450 hospital admissions for epididymo orchitis, representing a 4.2% increase over the prior decade, NCHS. Age distribution is bimodal, 15 to 35 years, peak incidence 1.5/1,000, and greater than 65 years, 0.9/1,000. Racial disparities reveal a 1.9-fold higher incidence in African American men compared with non-Hispanic whites. RR equals 1.9, 95% CI 1.6 to 2.2. Economic burden includes an average direct medical cost of US $2,350 per episode, hospital stay, imaging, antibiotics, and indirect costs averaging US $1,150 due to lost workdays, median 5 days. Modifiable risk factors, unprotected intercourse, RR equals 3.4, recent urinary catheterization, RR equals 2.7, and chronic prostatitis, RR equals 1.8. Non-modifiable factors, age greater than 65 years, RR equals 2.3, and congenital vas deferens anomalies, RR equals 1.5. Pathophysiology. The pathogenesis of Epididymo Orchitis involves ascending infection from the urethra or bladder, facilitated by the epididymal ductal epithelium's high expression of toll-like receptor 4, TLR4, and CD14, which recognize lipopolysaccharide, LPS, from gram-negative organisms. In younger men, sexually transmitted pathogens, chlamydia trachomatis, Neisseria gonorrhoeae, exploit the mucosal microenvironment, binding to the mannose-binding lectin, MBL, pathway, leading to rapid neutrophil infiltration. Molecular studies demonstrate upregulation of NF-kappa B within 4H of infection, driving IL-1 beta and TNF-alpha release. Serum IL-6 peaks at 48H, median 38 pg/ml, IQR 30 to 45, correlating with pain severity, R equals 0.62, P less than 0.001. In older or diabetic patients, urinary tract pathogens, E. coli, Klebsiella, ascend via reflux, aided by impaired bladder emptying and neuropathic dysfunction. Hyperglycemia, greater than 180 mg per deciliter, impairs neutrophil oxidative burst by 27%, P equals 0.02, prolonging bacterial survival. Animal models, C57BL/6 mice, show that knockout of the CXCR2 chemokine receptor reduces epididymal leukocyte recruitment by 45% and attenuates tissue edema. Clinical presentation. Classic epididymo orchitis presents with acute unilateral scrotal pain, 92% of cases, swelling, 88%, and erythema, 71%. Fever greater than or equal to 38.3 degrees Celsius occurs in 54% of younger patients but only 22% of older diabetics. Dysuria is reported in 46% of cases, and urethral discharge in 31% when sexually transmitted pathogens are involved. Atypical presentations, key points, elderly, greater than 65Y, patients may lack fever, present in only 12%, and instead exhibit confusion, 18%. Diabetics frequently present with painless scrotal mass, 23%, due to neuropathic analgesia. Immunocompromised hosts, HIV less than 200 cells/L, may have bilateral involvement, 9%. Diagnosis. A stepwise algorithm is recommended, Figure 1, not shown 1. History and physical, identify risk factors, sexual activity, urinary symptoms, catheterization. 2. Laboratory workup key points, CBC, leukocytosis 10 times 10 L superscript 1 in 68%, sensitivity 78%. CRP, greater than 10 mg per liter in 81%, specificity 73%. Urinalysis, pyuria, greater than 10 WBC/HPF, in 62% and bacteriuria in 48%. Urine culture, greater than or equal to 10 CFU/ml considered positive. E. coli accounts for 55% of isolates in greater than 65Y cohort. Management and treatment. Patients with severe pain, VAS greater than or equal to 7, or systemic signs, fever greater than or equal to 38.3 degrees Celsius, tachycardia greater than or equal to 100 bpm, should receive intravenous analgesia, morphine 2 to 4 mg 4Q4H-PRN, and fluid resuscitation, 30 ml per kilogram crystalloid bolus. Vital signs are monitored every 4H. Urine output greater than 0.5 ml per kilogram per hour is targeted. Empiric broad-spectrum antibiotics are initiated within 1H of presentation. Standard regimen, IDSA 2019, CDC 2021, indicated for sexually active men less than 35Y or those with confirmed chlamydia/N, gonorrhea risk. Key points. Fever persists greater than 48H, failure rate equals 12%. WBC remains 12 times 10 L superscript 1 after 72 hours, scrotal support, snug underwear or a jockstrap reduces pain scores by 1.4 points, p equals 0.03. Ice application, 15 minutes every 2h for the first 24h decreases edema by 22%, ultrasound measurement. Complications and prognosis. Major complications, complication incidence, mortality, testicular. References. 1. Justice ed et al. The 2024 European Guideline on the Management of Epididymo Orchitis. Journal of the European Academy of Dermatology and Venereology, JEDV. 2026, 40, 2166-173. PMID, 40698982, https://pubmed.ncbi.nlm.nih.gov/40698982. DOI 10.1111/JDV.20865. 2. Wang et al. Macrophage transition to a myofibroblast state drives fibrotic disease in uropathogenic E. coli-induced epididymo orchitis. The Journal of Clinical Investigation. 2025, 135, 19. PMID 41031892. https://pubmed.ncbi.nlm.nih.gov/41031892. DOI 10.1172/JCI193793. 3. Baper et al. Brucella epididymo orchitis, a single-center experience with a review of the literature. Archivio Italiano di Urologia, Andrologia, Organo Ufficiale di Società Italiana di Ecografia Urologica e Nefrologica. 2023, 95, 411978. PMID 38193225. https://pubmed.ncbi.nlm.nih.gov/38193225. DOI 10.4881/AIUA.2023.11978. 4. Hytham H.A. et al. Abdominal pain in children with COVID-19. Chirurgia. 2022 Wink with a Frown 1058-62. PMID 36223151. https://pubmed.ncbi.nlm.nih.gov/36223151. DOI 10.1711/Chirurgia 2022101558. 5. Mishra et al. Sodium glucose cotransporter 2 inhibitor associated severe epididymo orchitis. BMJ case reports. 2022, 15, 7. PMID 35817490. https://pubmed.ncbi.nlm.nih.gov/35817490. DOI 10.1136/BCR 2022-250942. 6. Yang YK et al. Incidental tuberculosis epididymitis/epididymo orchitis, a retrospective analysis at a tertiary center in Taiwan. Urology. 2022, 168:116-121. PMID 35798186. https://pubmed.ncbi.nlm.nih.gov/35798186. DOI 10.1016/J.Urology.2022.06.025. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.